Ira's title this morning is A Primer on Exercise Pharmacology. I think it'll match up very nicely with what we've just seen. Ira?
Thank you. And thank you, Phil, very much for the invitation and for actually setting me up. And Professor Braun, I'd like to, Dr. Barry, wherever you are, I'd like to thank you also. What an inspired arrangement of presentations, and they really do go together. And I look forward to sharing with you, for me, what is something quite new. This picture reminds me of a couple of things. One is change, and for me, it's a change. The change is in the days that when this picture was taken, I was a subject in my own experiments, and of course now ethically, you can't do that. So it reminds me of that kind of change. Now, in the old days, we used to do that a lot. The other change is one above my interests, associated with my interests throughout my career. So I have a little bit of a different perspective that I'll spend some time talking to you about. And most of my career, until 7 years ago, was spent outside of academia. I mean, I always had associations with two universities in Toronto where I could get graduate students to come and work in my lab. And my lab was one operated by our Department of National Defense. It was the only federal government human sciences research lab in Canada, where we had a few hundred scientists and technicians devoted specifically to working on human sciences research of relevance to the Canadian forces and supporting them. One branch of your military you may be familiar with is, if there are those who are or certainly those who are in physiology here will recognize USARIUM as being one branch. Here you have the luxury of having lots of money and lots of branches of the military with lots of parallel labs. In Canada we have one. But that enabled me to jump around an awful lot. In fact, it required me to jump around an awful lot to apply my own interests in exercise physiology, muscle metabolism, human physiology in general, to a broad range of actually very, very applied problems that confronted the military. And it's in that context I began to work with drugs. So what I'm going to do is talk to you a bit about drugs, talk about pharmacology in general, my different perspective. I'll elaborate a bit more about it, talk about the primer part, above a bit of an introduction to pharmacology, and then talk about the drug regulatory regime that has really, from my perspective, certainly neglected something that I think is very important. And I'm going to conclude by inviting you to join me, or to encourage those you work with to join me in trying to address what I think is quite important. Pharmacology, the study of or knowledge about drugs and their actions. Typically, pharmacology is divided up into two different areas. One, pharmacodynamics, which most people in my field, exercise physiology, are familiar with. They may not know that it's actually pharmacodynamics, but they spend their time doing that, looking at the effects of a drug on a biological system. We had a good introduction from the perspective of insulin that Barry talked about. Pharmacokinetics is something that has received much less attention, and that is really the effects of the biological system on the drug, on the pharmacodynamic effects, if you wish. And that's what I'm going to be focusing on. But first of all, let me tell you about why I became interested in it. And it was because of what most exercise physiologists who have ever studied ergogenic aids, performance enhancers, have been interested in, and that is the pharmacodynamics. So I'd like to just let you know, I have to do this because I found I run into problems otherwise with colleagues, that my perspective, remember, is different. My interest has never been, from a research perspective, in preventing or treating disease or illness or injury. But it has been in improving performance of people who benefit substantially, occupationally if you wish, from a performance enhancement. Sometimes their lives depend on it, in order to avoid the effects of fatigue, in people who are very, very healthy otherwise. That's how I became interested in pharmacodynamics. As a result of that, I spent a lot of time working with people who do what I did, both in this country, in the United States, Australia, the UK, a few other allied nations, and actually reviewing anything and everything that had ever been purported to be an ergogenic aid to see how it could be applied to support the performance of military personnel in very high-stress situations. And some of those things were nutritional strategies. Some of them were physiological adaptations that you'll be very familiar with. Some of them were drugs. So remember that the ethics of cheating are probably the last thing that anybody in the military is concerned about when it comes to performance enhancement. I hope you understand that, right? Okay. So we began to look at these kinds of things that you see here, these kinds of mechanisms that might enable us to identify drugs that could enhance performance, and of course not interfere with the health of the military. Sometimes may interfere acutely and transiently with the health, but perhaps the nature of the mission that these people were expected to do may outweigh those limited and well-identified health benefits. So that's the perspective part that's a little bit different perhaps than what normally we come to exercise physiologists, environmental physiologists come to the table with. Let me give you a couple of examples of the pharmacodynamic side of things just to exemplify it. This is a very typical slide. It's one individual, courtesy of a colleague, Tom McClellan, who worked with me for many days, where we did many years rather. We had sleep deprivation experiments, which simulated what sometimes military personnel are expected to do. And you can see, it doesn't matter what the test is, but this is pretty typical of a subject being tested over 3-4 days of sleep deprivation and seeing a cognitive decline, a decline in cognition that occurred as a result of that. And of course, one of the objectives for us was to be able to move that point of decline to the right. Well, one of the things that does it very simply, some people call it a nutrient, some people call it a drug, but it certainly, actually before I get to that, I wanted to show you this. The level of decline, you see on the right, these are Ranger soldiers, Ranger military personnel. So that's the kind of decline one can expect cognitively. And of course, with that cognition, sometimes they could be sitting in front of a computer screen trying to identify an incoming missile or respond to an alert of some type, and they have to be able to do that for hours and hours on end with little sleep. Sometimes it might involve actually undertaking some physical, deciding when to shoot, or make very, very critical decisions, right? That level of decrement is much, much greater than what we call impaired cognition that interferes with driving. When you are drunk, so to speak, or inebriated by law, your level of cognition is much less. In the military, here we are asking these people to make very, very significant decisions when their level of cognition is significantly more impaired. So is there a way to delay it, as I showed you in the previous slide? Well, there is, very simply. Caffeine could be a nutrient, it could be a drug. In the dose in which we use it, it's definitely a drug for this kind of thing. And over a period of a night where one normally sees, in the yellow, one normally sees this decrease in cognition. In this case, it was responding, it was a vigilance task, responding to on a computer screen to an incoming threat. One can actually avoid that decrement that occurs overnight, over a period of 24 hours, normally, with simply chewing gum that contains about 100 milligrams of caffeine. Give people a couple of sticks of gum, and you can avoid that decrement. So that would be an example of a study of pharmacodynamics and its application. I can think of another one that maybe you've heard about. In fact, I heard someone in the bus yesterday talking about hiking up at altitude, and there is a very, very serious malady that can occur with people who will go to altitude, a high acute mountain sickness, and it can lead to something called high-altitude pulmonary edema or high-altitude cerebral edema that can be fatal and can lead to stroke. We ran into a situation in Afghanistan, as did you. I say I am international, and I forgot to mention that. It's interesting. It depends on which meeting you're at, whether Canadians or in the United States are called international. But in Afghanistan, we were part of a group working with your nation and special operations personnel who on day one at 8 o'clock in the morning would be at sea level and would 4 hours later be transported to a significant altitude in the mountains of Afghanistan. Well, one of the things that military personnel would be concerned about would be developing this acute mountain sickness. Acetazolamide is a drug that had been developed to basically accelerate the effects of physiologically to accelerate the adaptive effects that normally occur at altitude in lots of people and reduce the incidence of acute mountain sickness. It does this by compensating for the normal alkalosis that occurs when you go to altitude but takes time to occur. And acetazolamide has a way of acidifying, if you wish, to put it simply, acidifying the body, making it more acidotic. Well, you have this normal decrease in oxygen uptake, maximal oxygen uptake that occurs with altitude. When you take acetazolamide, nothing happens. You're still decreased, but it certainly doesn't interfere. When, though, you are in fact engaging in very high-intensity exercise, here at 90% of VO2 max to exhaustion, you get a reduction at altitude, quite substantially. But when you take acetazolamide, it is worse, much worse. We had military personnel who up in Afghanistan, here, by the way, the Americans are the ones who are lying down getting treated. The Canadians are the ones who are marching by them. When we were told by the commanders in the field that they had this problem, I mean, they realized they were going to have a problem with physical exertion at altitude, but it was much, much worse than they expected. And we asked them, are you taking acetazolamide? Well, yes, of course we are. We're going to the mountains. We told them, don't. Not if you're doing the scenario I started off this part of the talk talking to you about, where you only get, in a space of hours, you're going from sea level or close to sea level up to altitude. Don't. And they didn't, and it helped. Another example of pharmacodynamics. So I've had this background looking at several other kinds of drugs, some of which subsequently were added to the WADA doping list. But from an operational perspective for the people that I worked with, it was quite important for their occupations. A couple of other examples. Now let's talk about the part that really, based on that, got me to thinking. And it really got me to thinking because in conjunction with the Canadian Forces operations in Afghanistan, we received anecdotal reports of people who were experiencing side effects of normally prescribed medications, non-steroidal anti-inflammatories, antihypertensives, SSRIs, even some military personnel take all of those, that were associated with being overdosed with a normal dose of medication they were taking. And the only common factor we could think about, without having done any research, was that there was a sudden change. There was a sudden change in lots of things, but a combination of stressors occurred. And we began to wonder, could those changes, not the least of which was this sudden increase in physical activity, prolonged physical activity, acute and chronic levels of physical activity, could have interfered in some way with the drug action? And I began to think, well, of course it could, and I hope to convince you that of course it could. And then I became even more interested in is there other research that actually would confirm this, of course it could, speculation on me. And that's when I became really infatuated by my discovery that there was very, very little. So let's talk about the fundamental of pharmacokinetics, so perhaps I can get you to agree with me. So for the pharmacokinetic side, I gave you examples of pharmacodynamics, remember. The pharmacokinetic side is really what the body does to a drug. It defines the onset, the intensity, and duration of a drug effect, the movement, the kinetics, the transients associated with the movement of that drug into the body and out of the body. And the terms that are commonly used, the short form is ADME, the absorption, the distribution, sometimes metabolism is included in there, the M, and the elimination of a drug. Those are the key variables when one talks about the pharmacokinetics of a drug. Absorption is basically the transfer of a drug. If you ingest it, the transfer of that drug from your mouth through into your intestines, where it's absorbed and gets out into the plasma. The distribution, oh, by the way, absorption is sometimes confused with bioavailability. You can ingest a drug. It can be 100% absorbed from your intestines into the bloodstream and not be very, very active, not have a good effect, because by the time it makes its way through the liver, it's totally metabolized. So the two things are different. Distribution, the reversible transfer of a drug to and from the site of measurement. Key factor I'll come back to. The elimination of that drug, which I think is self-explanatory. Lots of ways in which drugs are eliminated, and the key way is through the metabolism in the liver. Those things can be depicted if I drew a blood sample after ingesting a drug, whatever your drug of choice is, and I took a blood sample repeatedly. A blue line refers to that repeated measurement of blood. We have the maximal concentration that occurs after a specific amount of time, and this part of that graph is the absorption phase, attributed to absorption. We have the distribution phase after that, where the drug is distributed to whatever organs and tissues in the body it's going to. And then the elimination phase also, and typically the T1/2, the half-life relative to the time at which the concentration occurs, the peak concentration occurs, is another key variable. There actually are data that one needs to collect in humans. This is from one of my students who's just done a study on the interactions of exercise with a commonly prescribed drug, sertraline. But you can see that these curves are drawn, now I know what you're talking about, are drawn based on individual blood samples. So pharmacologists typically develop curves based on their knowledge of the transience of how drugs are metabolized to actually enable them to do these kinds of things. Decide how much, when you're developing a drug, how much of it you actually have to give and how frequently you need to give it in order to achieve a steady state for a desired drug. Typically, so I showed you, remember, the curve of one bolus of a drug. Of course, we take drugs frequently, daily. And what drug companies need to do is decide what is the steady state concentration that will give the desired effect of a drug. So they have to decide how much to give, and at some point in time, on a daily basis or repeated doses of a drug, the amount of drug that is actually coming into the system will be exactly equal to the amount and rate at which a drug is being eliminated. And that constitutes this steady state dose that we want to achieve. Normally, with most drugs, that is about 4 or 5 half-lives are required for that to happen. The key is to give enough of a drug to achieve a steady state where you're going to get the desired effect, and not give too much so that it's toxic, and not give too little so that it's ineffective. So that, we're talking here about the primer part of pharmacology, and it is very much a primer at this stage. Let's talk about something that most of you are a lot more familiar with, and I'm more familiar with it, and that is adaptations to exercise. Normal adaptations to exercise, right? We can increase the amount of blood that we're able to pump out from our heart out to our exercising musculature. Our body temperature goes up. Gastric motility is affected by exercise, slowed down acutely, certainly, during acute exercise. Plasma volume, we have an acute change where we have a drop during acute exercise, but one of the first physiological adaptations that occur with chronic aerobic training is actually an expansion of plasma volume very quickly, much before you see any adaptations in the heart or the musculature. Plasma proteins increase as a result of adaptations to aerobic training. Body composition changes, typically less adiposity, more body fat, and heart and skeletal muscle characteristics change in terms of their capillarization, in terms of enzymes that are in them. Do you think that any of those things would interfere with these? And I use these terms very broadly. Well, I do. I think they should. And I actually don't have time to go through them all, but I'm happy to respond to how. But there are lots of ways in which those things, if you think about them, why they would interfere with a drug, the absorption of a drug, its elimination, metabolism, and one of the key reasons is this very, very old work. Well, not very, very, very old, but old, very old, from 1964, showing blood flow to the liver, estimated blood flow to the liver, changes as a function of exercise intensity. And you can see these changes at even a 60% VO2 max exercising, you have about a 50% drop in blood flow to the liver. Confirmed recently with Doppler blood flow, showing even an acute bout of exercise in this case, with time, at 70% VO2 max, this drop in blood flow to the liver. I just want you to think about this for a moment again. This is showing a schematic from a good textbook that I borrowed from here, just to show how our cardiac output is distributed to a variety of organs in the body. And I want you to pay attention to two. One is the difference between rest and exercise of what goes to muscle, understandably. This is the percent of cardiac output. And to liver, this huge drop. Why am I focusing on liver and liver blood flow? Well, because this family of proteins, what are called cytochrome P450 enzymes, if you wish, there's lots of them. There's lots of families of them. They are responsible for most drug metabolism, mostly in the liver. I won't go into details about the family of them, how they might be affected. But there are electron transport chain terminal enzymes that are, in fact, very responsible for removal or the conversion of drugs, sometimes to active forms, mind you, but usually to inactive forms that can subsequently be eliminated by the body. And thank goodness they're there. So here's a schematic from my student who's just about to commence his data collection, basically showing what I showed you before, showing this is from some modeling software that we used, showing the effect normally that would occur in reaching this steady state over several days of administration of a drug called sertraline. You may know it as Zoloft, one of the most heavily prescribed drugs in North America right now, an anti-anxiety, antidepressant drug. And here is what he is, oh, I guess I should back up. So pay attention to the unit here, the level of drug concentration in the blood, 6, that he expects to achieve normal, which is normal. And here's what he anticipates will happen with exercise. And that is that level 6 over a period of days will gradually move up because of the reduced blood flow to the liver, so that less drug is going to be eliminated and metabolized than without exercise. And if we extrapolate that over a number of days, you'll understand the fear or our suspicion that the actual concentration of the drug will back up. And we're using this as an example. So we have some other studies going on. One is with a contraceptive patch, commonly used. There are concerns about the area under the curve, the duration with which women may be exposed to estradiol as a function of the patch. I'll come back to that in a moment. We have some studies going on looking at the effects of the acute effects of exercise on ingested sertraline pharmacokinetics, as well as on the enzymes themselves. Is this a public health issue? Well, it won't surprise you to learn these data in the United States, certainly, that a lot of us are heavily medicated. It's going nothing but going upwards. The regulatory background is no different here than it is with the FDA, in the FDA, as Barry told you earlier, than it is with Health Canada. We have regulatory agencies that in theory are protecting us and about drugs and asking drug manufacturers to actually test the safety and efficacy of drugs before they are marketed. We have clinical trials that are required by law for them to collect the data to demonstrate the safety and efficacy. If you look at these clinical trials, some preclinical investigative work, usually with animals, phase 1 trials, those are basically safety studies that are done in healthy individuals, usually to identify the doses that are required, the frequency of doses that are required. Phase 2 trials, a small trial, usually where a drug is used with the patient population with the malady that is trying to be treated. Phase 3 trials are more extensive, multi-center trials that are generating where lots and lots of individuals with the malady are being tested, usually compared to a placebo control. In a placebo-controlled series of trials, and the phase 4 trials are referred to as all the data that's collected on a specific drug after the drug is already marketed. At no stage is there any requirement, as was already pointed out, to investigate the interactions of exercise with drugs, in spite of the fact that we've been doing a wonderful we can debate that, I guess. We've been doing a wonderful job of informing the public and encouraging the public and motivating the public to become increasingly physically active. From my perspective, certainly, the lack of attention that we have collectively been paying to the interaction of exercise with drugs is at the very least disconcerting. So my hypothesis is that my hypothesis for our new research program is that there are a variety of stressors, among them exercise, the one I'm most interested in right now, that do have interactions with pharmacokinetics, which we don't currently expect, and that there are people who are either underdosed and receiving an ineffective dose of a specific drug, depending on the mechanism of action of that drug, or they're overdosed and experiencing side effects and not really attributing it to the exercise as a result of the fact of some of the interactions I've talked with you about just now. We're doing proof of principle studies to make the case and to hopefully heighten the awareness of our drug regulatory agencies to this issue right now. I'll give you one example I mentioned before. This is an interesting study, and what it is with the Evro patch. Basically, this study was funded by the manufacturers of the Evro patch to look at to see whether the adhesive on the patch was good. And they put people in a sauna, whirlpool, treadmill, had them in cold water, combination of those variety of things. No exercise, but there are differences. And if you look at these graphs carefully, you're looking at the area under the curve. This is the drug concentration delivered by that patch through the skin. There are huge differences. And some of those I could attribute to, just speculative, to the changes in body temperature. And we have now preliminary data. Jason Vescovi is a postdoctoral fellow in our lab who has now demonstrated this shift. The green is with elevations in body temperature showing this increased area under the curve for exposure to the estradiol. That's, for those of you who know about some of the risks associated with that, that's disconcerting. So we hope the output of our research will result in a new theoretical model of some pharmacokinetic factors and interaction with exercise. We hope to look at a variety of different classes of drugs. You can't examine everything, but we think there are new ways that actually will enable us to actually look at the enzymes that are sensitive to this interaction in one and the same study, multiple enzymes, rather than actually studying drugs, to be able to identify classes of drugs that will be susceptible to exercise interactions with their pharmacokinetics. As I said before, we suspect that there are health risks that could in some cases lead to toxicity associated with acute and chronic exercise taken in conjunction with drugs. The whole whack of drug classes that one could investigate, we're certainly not going to be doing it all. We're going to do very, very little of it. I can count on one hand right now the number of investigators that I'm aware of around the world that are actually looking at this or trying to address this issue systematically. There are very, very few. So wide open area. I invite and encourage others to think about this. So wonderful job we've all been doing collectively about passing on this message about exercise as medicine, but I would just like to add and finish with adding a little flag, and that flag that medicine may be interfered with by exercise. Thank you.